Hello, good morning, everyone. Welcome for today's podcast. I'm Dr. Farooq from ER Skill Lab and Bangladeshi Emergency Medicine Community. Uh, Today we have Dr. Shabnas. Welcome, Dr. Shabnas. Dr. Shabnas is an MBBS diploma anesthesia, MRChem, and PG diploma in the background. She's a specialty doctor in anesthesia and ITU in Northwest Anglia NHS Foundation Trust. We are really happy to have you today, Dr. Shabnaz. Um, could you tell us a brief about your journey from Bangladesh, what you did in Bangladesh, and until where you are now for the audience? Thank you.
Thank you. Thank you very much, Dr. Farooq. And thanks for having me. Good morning, everyone. I'm Shabnaz, so basically origin from Bangladesh. So I was basically an anesthetist in Bangladesh. I started my anesthesia training. I finished it, my post-graduation, and I was a junior consultant of anesthesia Bangladesh. At that point, basically, I um, grow interest in emergency medicine. Uh, if you ask me from where I get all the interest, basically all are from the YouTube videos, some kind of 24-hour and any kind of stuff. And those things were basically matched with my anesthesia background as well, because I was working in a trauma center in Dhaka. So I started to looking for emergency medicine career in Bangladesh. And as you all know, emergency medicine yet not that much popular compared to other specialty in Bangladesh till now. So at that point, I did some Google and then I got to know about emergency medicine subject in UK. So I started my preparation for MR Camp in 2021 and I appeared in exam, and that time I was working as an intensivist in United Hospital Dhaka. And by this time I started my government job and I finished my MR Camp OSCE in 2022, and then I came to UK. So I initially started my career in emergency medicine in 2023. I worked as an ST3 in emergency medicine for 2 years. Uh, With that point, I had a huge experience and exposure in emergency medicine, which I liked a lot. And still, I like emergency medicine a lot. Uh, After some point, I had to get some competencies things in UK in anesthetic point of view. So I was looking for a anesthesia and ITU job, and I was lucky enough that I got the job in same trust, and I switched my department, and now I'm currently working in anesthesia and ITU for last 7 months.
Thank you so much. It's a very interesting journey from anesthesia from in Bangladesh, then MRChem, and then ST3 EM. And now you're both anesthesia and ITU special doctor. Thank you. I think it is a huge experience. First of all, you have experience in Bangladesh and in UK, both in emergency, anesthesia, and ITU. I'm sure the audience is excited to listen from you. Um, should we start? Can you tell us some of your examples where you that some patients ended up needing an intubation? Can you briefly tell us at the beginning part what happened to that patient? How did you came across to see that patient?
Yeah. To be honestly speaking, while I was working in emergency medicine, as an ST3, I hadn't had any practical experience to do intubation on patient practically. However, my patient got intubated and we transferred the patient. But currently, when I joined anesthesia and ITU, I am being calling when I am an on call to intubate the patient in emergency recess. So whenever a patient came in, basically we do have an on-call bleep in hospital switchboard. The ambulance people, that is the pre-hospital emergency medicine, they pre-alert the switchboard or recess red phone, and they inform everyone that we are expecting a patient and a short brief history. What is the cause of coming the patient? What about GCS? What about airway? and why they are expecting us to end up in recess. So the most of the time, it's unconscious patient, GCS low, less than 8 or 9 GCS. Some of them from stroke, some of them from trauma, some of them have seizure. So those patients came and we have been called for maintaining the airway. For my practical experience, the people most of the time I get, those are for intubation for low GCS, number one, and number two, for transfer of the patient, either in other hospital or for in another department, like for imaging, CT scan or MRI, or patient is going to be admitted in ITU, so patient need a definitive airway management. For that reason, they call us for intubate the patient. So my practical experience, the recent one I would like to share with you, we do get a pre-alert, and when we ended up in ED research, we do have uh, got doctors from medicine, we get doctors from ITU, we get doctor from anesthesia. And based upon their specialty, like if it is trauma, surgery and orthopedics also came in to the research, and we gather in a specific day, which is the patient will come in. At that point, the ambulance crew bring the patient, and they give handover to the patient. So the pre-hospital, they did everything, whatever they can do. Most of the time, they don't intubate the patient, but put a nasal airway or oropharyngeal airway, and then we do a hands-off handover, all of their specialty. So what happened in my case, it was very obese patient, and she had severe headache since morning, and around 12:30, the fall, seizure, and unconscious. So initially they were thinking about patient head injury, while there was a chance of having an intracranial bleeding followed by unconsciousness and seizure. So that patient's GCS was about 8. Patient vomited in front of us for 2-3 times, and his GCS was dropping, non-responsive patient. So we had to intubate the patient, and most of the time when it is comes up that emergency intubation, we usually follow rapid sequence induction followed by intubation.
Dr. Shabnaz, I'm going to stop you for now and summarize whatever you told us for the audience. Is that okay? Right.
Yeah.
So, audience, again, who are joining late, just to update you guys. So, we have Dr. Shabnaz is a currently anesthetics and I2 specialty doctor, and who comes down almost every day to emergency department and for any patient likely needing intubation. So basically, I think it's a very common scenario she was describing where most people come to ED with low GCS. And in this particular case, this was an obese female with headache, fall, and GCS was 8. So definitely, anyone with low GCS, we worry about airway aspirations, all those risk factors before we transfer those patients to CT scan. And in that particular case, so Dr. Shabna, was it a trauma call, if you remember?
Yeah, initially it was a trauma call.
Okay. So if it is a trauma call in UK setting, what are the other specialties came in for that case?
Yeah, for if it is a trauma case, then surgery on orthopedics, these are the specific specialty they came seen along with other specialties.
Right. So definitely it was run by ED team. Also, there is orthopedics, surgeons, and ITU specialists. So tell us. So by the time you came downstairs to receive the trauma call, did you came down before the patient arrived? So you had a pre-alert. So okay, tell us when the patient arrived, what happened? What exactly
Right.
happened when the patient arrived?
Right. When the patient arrived, they brought the patient in resus, and patient was in his left lateral position at that point. Patient was completely unconscious and had once vomiting in ambulance, and patient had nasal airway and oropharyngeal airway in situ, and patient was having oxygen by 15 meter of non-rebreather mask. and patient was completely flat position. They told that they couldn't put the patient in a trauma board because they thought that it's not a high force injury which can causes in primary survey, pre-hospital primary surveys, there was not suspecting. However, as because patient was vomiting to prevent aspiration, they put the patient on left lateral position.
Thank you. So, how old roughly was the patient?
He was 62 years old.
So 62 years old, obese, of course, vomiting and contrast and fall. I think for the audience in UK settings, the pre-hospital ambulance guys already put the patient in left lateral. Of course, if someone is vomiting, you don't want them to be in supine position. They put oropharyngeal and nasopharyngeal airways to oxygenate and giving 15 liter of oxygen. Did they have any IV access or anything?
No, basically that point they hadn't had any.
Okay, so that the patient arrived. Okay, fine. And then what happened next?
Right. So we take the handover from the ambulance crew, everything, and the team, we allocate ourselves who is gonna do what, and one specific person, that one was the ED consultant, who was in leadership position to guide everyone and organize things and everything, communication staffs. And then, as an anesthetist, I was in the head end to patient to assess the airway. One emergency medicine register, he started to do primary survey on the patient. And then who was the surgical team, they were stand beside to get the informations what we are going to do. There were two nurses, one of them started to put in a IV access and take the blood samples and everything and start the fluid. Another nurse, she assigned for managing the equipments and drugs, everything if needed. So we allocate everyone. Basically, we allocated before the patient arrived. Then when patient arrived, we distributed in our assigned position.
Thank you. Thank you.
From my point of
Mhm.
view,
Thank you. I'm just going to summarize for audience in Bangladesh. I think most of them don't have this set up in our ED. So all the audience, we are listening to a real life case where in UK ED settings we get the pre-alert. It's a red phone call roughly 10-20 minutes before the patient arrives. As Dr. Sharma rightly said, the whole team is actually bedside in resuscitation bay for that patient. The whole team, including ED consultant, ED registrar, ITU, general surgeons, orthopedics. And by the time they arrive, usually there is a brief, like a debrief, what sort of patients coming in. So, and everybody is given the role, allocated role. So usually the ED consultant or who is leading the trauma call allocate. So anesthetics needs to go into the head end to check the airways. Then general surgeons, the orthopedics there, and also one of the register is allocated for primary survey. As you rightly mentioned, there are two nurses, which is sometimes doesn't happen, but one nurse is to get the medication, another nurse is helping with the IV access. And was there anyone allocated for scribing or writing? Uh,
not really at that point. And you know that we do have a lack of manpower at that point. We have to run other areas of ED. So basically, what happened? Who was doing the team leader, the emergency medicine consultant? He basically keep everything in his mind and instruct everyone what to do in the next part.
and do we follow that trauma booklet, that the East of England trauma.
Yes, yeah, yeah, yeah,
So
yeah.
tell the audience that we follow a standardized trauma booklet in East of England that is printed, that's in all the hospitals that within the East of England. I think other regions have their own trauma booklets. And this standardized trauma booklet is for someone to document from everything from handover, pre-alert handover, and ongoing activities. Everything is documented in trauma booklet. Usually, if it is team leader or if you have enough manpower, we can allocate someone just to document that booklet. So thank you. So we got allocation and the patient arrived as you described. What happened afterwards?
So we allocate everyone. And then we started to do our jobs individually. For my point, I found the patient airway is not maintaining, and all the monitors was put it on by the nurse who was assigned for the equipment things. So basic monitoring all started to have. Ambulance crew were still there if we need some more information about that. And by this time, the team leader was taking some more information from ambulance crew, because they do have, as you know, obviously in UK we do have everything patient record system, which is in online system. So they have more access in pre-hospital emergency medicine, and based upon our requirement, they get those information and convey to us. Like if I need any information from them, they will give me. If from medicine or surgery point they need some information, they usually convey the most specific information to them, which might not needed from another people. Anyways, for my point, I took a patient. He vomited twice with me, so I make the decision rapidly. We are gonna intubate the patient to secure the airway to prevent aspiration, and he was very obese, and we couldn't get the patient's neck and everything. So I quickly did my airway assessment, and the vomiters, that one was food content. So I assume he had his meal maybe 1 or 2 hours before he passed out. And from emergency medicine point of view, you are checking if there is any trauma, if there is any fracture, if there is anything. The medicine who was there, who he was auscultating the chest, and he grabbed the echo machine to do the echo of life support. We do, if we do have qualified person who can do the echocardiogram, we do e-fast, or we just left it as a trauma call. And then when we decided the intubation, our plan obviously in emergency medicine, as you know, 25% of all the RSI are in emergency medicine, and probably 100% of emergency medicine and intubations are rapid sequence. So we do have a booklet of checking checklist to tick mark to gather all our equipment and everything to do.
Can I just stop and summarize for the audience? Thank you so far. I think now we are moving forward from the initial assessment point of view. I think Dr. Shamnas rightly mentioned that she was in the head end. There was obese 60 something or old male is vomiting in front of her. And obviously the air is not secure. GCS is low. And she decided to intubate that patient, obviously, and at the same time the whole team is doing their own jobs. When you say you assess, well, I'm assuming by that time the patient was in trauma board or not in trauma board
Yeah, patient was in trauma board.
with collar and blocks.
Well, patient had not the cervical collar, which we usually do. He had a block. However, patient was in left lateral position, so we had to maintain the C spine stabilization at that point as well.
It is, I think, it's a very bit of difficult scenario where
Yeah,
patient in left lateral position, you put something not like a typical block, something to stabilize the neck, or someone asks to someone to hold the neck, and at the moment the patient is vomiting. I think it's a very challenging situation. And you said you briefly assess the airway. How, as an anesthetist, how do you assess an airway? Just for the audience, what are the things you're looking for?
yeah. For airway assessment, there is a mnemonic we follow. I mean, I follow lemon assessment. Look at first. I see how the airway looks like. Is the patient is very obese, how their mouth opening looks like. Obviously, for this patient, we couldn't get that information. If there is any beard or not, if it is definitely, it would be a difficult bag marks ventilation. Then we check about the neck, how the neck looks like. It is a short neck. Is it an obese patient? If there is any visible injury in the neck or not. Then if patient can open their mouth, we check the denture as well, how the denture is, if there is any loose teeth, anything or not. Based upon all those things, we maintain the airway.
Thank
If it was not that situation, routinely we sometimes check the finger. distance and everything to check how the airway looks like. Um, for my point of view, this patient had difficult intubation because of the obesity, unstable position. We don't know about cervical spine. We have to immobilize that. And most importantly, the patient was vomiting, active vomiting.
Thank you so much. I think this is very key learning from all the audience. I think any patient in trauma board, or if you stabilize, have to stabilize the neck, it is a difficult airway by default. On the top of that, it was a, I think, obese male, probably have a short neck, vomiting, and probably you can't even assess the mouth, you can't ask them to open the mouth. So all these things, and obviously you mentioned the mnemonics, which is important. So there's a very quick assessment from the head and from the anesthetic point of view, that immediately in any patient in trauma board with this, all these other features at the same time, make it a difficult airway. Okay, fine. So you, and then at the same time someone else was doing the echocardiogram, bedside echo, to see is there anything else. Thank you. So from your point of view, so you decided this is, you need intubation. Second of all, it is a difficult intubation. So how did you prepare for the intubation, or anyone else with you to help you in that preparation?
Actually, in emergency resus, we do have a equipment check, uh, uh, RSI checklist to make sure that we are safely doing the procedure. At that point, I did ask for the help. Luckily, there was an ITU consultant over there, and he also has background of anesthetic as well. So he was there. So we allocate role. I will be the first intubator. If I fail, he will take over the intubation procedure. So according to the checkbook, we do check certain things to make sure the procedure goes smooth and intubation becomes secured, and short time we don't ended up with any unexpected situation at that point. At first, we do check pre-oxygenation and then appropriate monitoring or not. Like for intubation, we do check ETCO2, which is the added one if someone is ended up with intubation. And then we did check the appropriate patient position, like if I am comfortable with this position or not. And as you know, we always want a bed, the head side we can tilt up and down to maintain the position. As because the patient is obese, we had to maintain a certain position. Theoretically, we tell is ramping position. However, practically, we cannot maintain the position in emergency resus. However, we do put something under the shoulder to make sure that patient is in a position that their ear is aligned with their chest.
Thank
The
you.
reason behind
No, I'm just going to summarize. I know you are, you mentioned about RSI checklist. I think, and you said you had help, of course, in your situation. Even as an anesthetist, you need help and you need the checklist. That's I'm trying to telling to everybody. So even if you're in the head end, even as an ED or ITU registrar, or if you're going to into bed, you make sure you have extra help. Obviously, it can be another anesthetist or IT consultant, or even sometimes we have ODP. Okay, to come and help you prepare the RSI equipments, and or if you're a first intubator, is do you have a backup like a second intubator uh, waiting? The key thing is, I think I like the idea of RSI checklist. This is not, sometimes it can be ignored in some ED. I've seen that they are doing intubation without going through the RSI checklist. RSI checklist is a nationwide standardized checklist that covers, I think, anesthetics, ITU, ED. Everybody follow the same checklist in UK, and I would highly recommend for all the audience to have a look or search for the checklist. If not, we can share with this with your emails later on. And with that RSI checklist, also Dr. Shamnaz was rightly mentioning that she was going through the monitoring, what the patients are, of, all the monitors on, the observations like heart rate, blood pressure, pulse. ETCO2 is another key important that is attached to the monitor. To make sure that ETCO2 is attached. And then you talking about positioning the patient, which is very challenging in this case. Can you, and you said if it is an obese person, ideally we should have a ramped up position. There's like a in a specific like a triangular. As far as I remember, to extend the neck, you need to put something behind the shoulder, but we don't have that device in ED. So you put something under the shoulders to make that position as I would say, as ideal as possible. Can you tell us a bit more about the positioning in this patient? Initially, you did mention that he was or in left lateral position. Did you move her to in back in supine position and put that on the shoulder or not?
No, not immediately when we make the decision because patient was actively vomiting. However, our plan was whenever we will be ready, we will make the patient in a supine position on their back. So practically, we usually do in our research, we put a towel. We do have lots of towel on the back of the shoulder, 3 or 4 towel we put under shoulder and one under head, and someone uh, standing beside me. For my case, that consultant, IT consultant was there who was helping me with intubation and assigned for second intubator as well. He was holding the head and he basically pushed all the towels behind patient's shoulder because he was in left lateral position. In that point, we put all those things aligned with his shoulder so that when we'll make him in supine position, he will be on the position straight away. So that's how we maintain the position. Another thing, we did mention the uh, height of the table, as we do have, my height is not that great. So what do we have? We have a step in all the recess. If the bed need to be aligned for everyone, I had a step, and everyone was trained, and that ODP, he put the step on under my foot so that I can maintain the position. So my comfortability was another important thing, that if I am happy with the position or not, and patient position.
Thank you. So I think you really, it is really important for all of us to listen and understand how important to position yourself, as Dr. Shambas said, adjust the height of the patient so that during the intubation you're not too below, or is not too high up. So adjust your position or the patient's position in your comfort zone while you maintain the patient position, prepare for the patient positioning. What she was describing, the patient was initially in left position and the consultant behind her was organizing some towels so that whenever she moved to the supine position, we have the support behind the shoulders and have this airway opened up when she's ready to intubate. So that's the positioning. I really like the idea of positioning. In terms of equipments, can you tell us what are the equipments you needed ready for that time?
Right. For the equipment, at first foremost, we needed suction, active suction. That is one thing. The running suction was below the patient pillow, because we do have sucker machine in each and every resus bay. We needed airway rescue trolley. In airway rescue trolley, we do have everything. However, in Bangladesh perspective, we don't have that rescue airway trolley. We do have separate dryer, plan A, plan B, plan C, plan D. If we need it, we just need to open up that drive. And as because we already assess the patient as a difficult intubation, the laryngoscope, choice of laryngoscope, we goes straight away for CMAC, video laryngoscope, so that we don't lose any time with conventional laryngoscope. And monitoring, we already mentioned what was the monitor we needed. Uh, yeah, that is the things was there. Actually, our job concise enough because we do have organized trolley over there so that we don't need to gather things.
Mm.
And within the trolley, we do have all the medications as well. Like we do have a box, a black color box in recess freeze. So if we need any RSI, then we just need to grab the box and open it up, and all the medication are within it.
Thank
So
you.
for medication point of view, practically there are lots of variation, person to person choice, what agent they are going to use, that is their personal choice.
Thank you. Thank you. So it's very important. You mentioned about suction and the airway trolley that in UK settings we have A through E, A, B, C, D. And since you describe as a difficult airway, um, if it is a difficult airway, is there anything? So can you talk us through A, B, C, D? What are the things we're looking in the drawers like A, B, C, D uh, for the trolley for the audience just to understand?
Yeah, for A already, to be honest, A part already done by pre-hospitals, because for A we usually put an nasopharyngeal airway or oropharyngeal airway to maintain the airway opening. And it's grossly said if someone is tolerating oropharyngeal airway, that means that patient needed intubation, because people cannot tolerate oropharyngeal airway until their GCS is not less than 8 or not less than 8. So A, the basic adjunct, airway adjunct. Then uh, drawer B, we do have supraglottic airway devices. In UK practice, we do have IGEL and LMS. That is the Orogen. We use that one. And Plan C do have endotracheal tube. That is the conventional. And Plan D is equipment for front of neck access.
Right. In your case, did you use for airway, for example, intubation? Did you use direct laryngoscopy or video laryngoscopy? Did you have
No, we do. Yeah, we use CMAC.
CMAC? CMAC. So this is another thing. I don't know if we have it in Bangladesh. Do you have this in Bangladesh?
Well, we do have, not everywhere. In corporate hospital, we do have, and we do have some video laryngoscope. I have seen some anesthetists for their personal interest. They buy those by their own. And recently, I have seen someone shared in anesthetic group that they are making it manually,
Yeah.
attaching with their mobiles, just for video laryngoscope.
Okay, thank you. Because this is the scenario. If I'm doing intubation, I would go for video laryngoscope or CMAC because is with direct laryngoscopy in this in difficult airway it is going to be challenging. And s- sorry about it. So in this scenario, I would say it's going to be very challenging.
Yeah, in that case, I would like to add it and that RSI, we do cricoid pressure, and cricoid pressure make our job more difficult, because that often the airway anatomies, and we can't see anything. So
Hmm,
that is another thing made the intubation difficult.
thank you. And what I was trying to say that in this video laryngoscopy is very key. Do you have considered bougie at the same time? Bougie?
Yeah, yeah, of course. Yeah. Uh, Honestly speaking, if someone is, if we assess someone as a difficult intubation, we use stilette or bougie. Uh, for my practical point of view, I never go for endotracheal tube alone. I always use stilette or bougie, because I don't want to take any risk.
It's very
I
important.
mean, no one will stop you to make your procedure more safe. But there is no point to present yourself as a hero and put a patient in a dangerous situation. So I always use air adjunct to for my intubation.
Thank you so much. I think I also like the idea of bougie in this scenario, or in case, as you said, almost any intubation. I think ideally we should have bougie in hand. And if you're predicting difficult airway, I would say go with bougie first and then go with intubation, which is a standard practice in UK, probably not standard in Bangladesh yet with bougie. Um,
In Bangladesh, if someone is assuming difficult, when I was practicing, we invariably use stilette, but not bougie.
Dilek,
Bougie practices, yeah.
can you tell for the audience what is the difference between a
Bhuji is used nowadays. It's very common. We are practicing, okay?
I'm sorry. Say it again. Who is this?
Bhuji is used commonly nowadays in Bangladesh also.
Dr. Menas Ferdos, thank you. Dr. Menas Ferdos is telling that we are commonly using a bougie. Hello?
Yes, I'm working at a corporate hospital and we are using Bougie commonly.
Okay, good. Thank you.
Actually, in corporate hospital, I would like to add it on that they do have all the airway adjunct airway equipments as like as UK. But I was working in government hospital in a medical college hospital. We barely do use Fuji, but Stellate is
Yeah.
common and a very common practice everyone, even in private clinics.
Even in Bangladesh, as an if you're a corporate hospital, you may have bougie, but not everywhere else. It's not a standardized practice in Bangladesh, but I would say in UK practice is standardized everywhere. Okay, thank you. So in terms of equipment, you have CMAC, bougie, suction there. What else and what size of ET tube you use in that scenario?
In endotracheal tube wise, the first choice is as wide as we can. So for this patient, we did use 8.5 because this patient was big enough to, however, we had an undersized tube as well. Like we did had 7.5 in hand, and we had two more laryngoscope blade. So if we are not getting in, we can change the laryngoscope blade straight away.
So different size laryngoscope blade and difference of ET tube depends on how the size of the patient. Um, right. In terms of medications, RSI drugs, what are the drugs you prepared, and who was doing the drugs with you?
Uh, Basically, in our trust and hospital, we do have pre-prepared a box in freeze already prepared so that we don't need to waste our time to making the drugs. This is varies depend upon person to person and patient as well. For induction, if the patient is hemodynamically compromised, very common practice that we do use ketamine on those patients for sedation. However, even if patient I have seen that even if patient have some sort of hemodynamic compromise, we don't use ketamine to prevent other complications. Like ketamine also can causes as induce vomitings and kind of stuffs. So I most commonly we do use propofol for patient induction along with any opioid, fentanyl or alfentanil. Personally, I like alfentanil rather than fentanyl if I'm going for RSI. And for muscle relaxation, that is also varies upon person to person. Now it comes up a modified RSI, conventional RSI, that is the classic one. We do use hexamethonium, but for the modified RSI, we commonly use rock uranium. For my practice, I do use rock uranium rather than succinylcholium. That is another thing. And followed by the nurse who was assigned for medication. When we make the decision we are going to do for RSI, she make the syringe for subsequent maintenance of the anesthesia, because those patients woke up very quickly and they might have awareness. To prevent that one, we made the propofol infusion ready to continue the uh, uh, uh,
Today.
sedation.
Thank you. You did mention in this part, so you did mention as I said, you use ketamine in this scenario or propofol.
Now, in this case, we use propofol.
Propofol, okay. And for analgesia, you use alfentanil. You prefer alfentanil compared to fentanyl. Why is that?
Well, for my alfentanil onset of action is quick and more potent than fentanyl. If we goes in term of airway reflexes, it's a alfentanil is suppress airway reflexes more than fentanyl. So for that reason, I use alfentanil. I prefer to use.
Thank you. And just for me, because I normally use fentanyl, what's the dose of alfentanil? What's dose range?
Well, for this patient, we do have 100 microgram ampoules. So I use for this patient, I use 1,500 microgram because of the obesity.
Okay, okay. And how much propofol in for this patient?
Well, for this patient, uh, for RSI, it usually said that up to 2 milligram per kg body weight. However, until the patient is not getting sedated, we keep using propofol. However, for my patient, as because this patient's GCS was already dropped, so we didn't needed lots of propofol. And as because I'm using alfentanil, so for airway reflexes, I didn't bother about more propofol to suppress the airway reflexes. So I did use 200 milligram of propofol in total.
200 milligram. And when you say obese, how much body weight roughly that gentleman had?
I would probably say around 120.
120. Okay, fine. Again, I think this is important sometimes is someone is already dropping GCS. He probably didn't need a full 2 milligram per kilo dose of propofol. Also you using alfentanil or fentanyl, that will reduce the dose of propofol anyway. That's the one thing. And how much rocuronium?
Yes. Rocuronium for this patient, I use 50 milligram first, and then we assess if the patient has, I mean, my airway, I can open the airway or not. Followed by, I give another 25 to get my full relaxation.
I see. So, and who was allocated doing the sedation? Someone, it was the consultant or?
Yeah, the consultant who was standing beside me, he was doing the drugs.
Okay. So, so now again, thank you. So going through that RSI checklist, so you, first of all, you optimize the patient, the monitoring, observation, position, suction, and everything. Then in terms of equipment, so you have all the equipments, drugs. Okay, you mentioned about post intubation sedation. I think this is very important. Some people sometimes forget to prepare in advance. So you said there is a propofol infusion that's usually ideally should be ready for post-sedation intubation. Um, and then I think because you are planning to take this patient to CT scan, so you need a portable ventilator ready in ED, isn't it, Oxylog? Can you tell
Yeah,
us
yeah.
that
Uh,
device?
before I go for Oxylog, I would like to inform about cricoid pressure, which is also very, very important for RSI. I mean, cricoid pressure make the difference between conventional intubation and rapid sequence. So there was a person who was already allocated for a cricoid pressure.
Thank you.
If it is
Yeah, go for it. Yeah.
Yeah, if it is a alert patient, so we go for around 10 Newton, which is in rough term 1 kilo of pressure, and we do ask a patient that I'm going to put some pressure on your throat. Don't being panic about that. And after pushing the induction agent, I mean middle of the induction agent, when they started to being a bit of drowsy, we change it to 30 Newton, that is the 10 kilo of pressure over the cricoid to prevent rather aspiration when patient will be relaxed. Yeah,
You did
that
say it
is.
was allocated for cricoid, but this is something's very important. Sometimes we forget. Um, and and then before going to Oxylog, can you mention about pre-oxygenation and how did you provide the
Yeah,
pre-oxygenation
yeah,
patient?
yeah, yeah. Actually, for pre-oxygenation, patient was already on 15 liter of oxygen. That is one thing. So we had a circuit, and that circuit we check when patient was on a left lateral position. Everyone was ready with everything: cricoid pressure, drugs. I was ready with my laryngoscope, my tubes, and everything. So I had an OTP with me. He changed the circuit and attached it with the oxygen supply in recess. And the plan was whenever we will bring the patient in supine position, we will started to do everything in at the same time. And the team leader was allocated over there. He will make sure that everything is going on in a synchronized manner. So trachea pressure on, patient was bring in the supine position, pushed the drug. I changed that 15 liter of non-rebreather with conventional bag valve mask ventilation. So as because patient was already in high flow oxygen, we didn't do pre-oxygenation that much. However, when I am doing ISR in theater, we go for pre-oxygenation conventionally. And one thing more, we do have oxygen sensor. In oxygen sensor, expired ETO2, how much it is. It usually said it should be more than 89. So patient already had 100% of ETO2. So we didn't go for that conventional 3 minutes of pre-oxygenation kind of steps.
Right.
And as because he was vomiting, we didn't take any chance to for pre-oxygenation to insecure the airway.
So he
Yeah.
was.
So it was just a practical decision.
Yeah. So you're saying that this patient was already on 15-liter oxygen and maintaining the saturation. So you didn't need to do much of pre-oxygenation. Did you mention about use the water circuit in that patient or no water circuit?
Yeah, water circuit.
So can
Yeah,
you
water circuit.
tell us for the audience? I think a lot of them are probably may not be anesthetic background. So what is a water circuit and how it helps in this situation?
Water circuit is a circuit which is one port is attached with oxygen, another one is attached with a ventilator, or we can do manual ventilation with our ventilator bag. It does have a adjustable pressure limiting valve so that we can adjust the pressure according to patient requirement. And the another in we have a universal port to attach with mask. And there is another port specific for expired air to go out of the theater environment, uh, uh, along with in theater practice, if I say the volatile agent we use, it goes out of the theater environment. So water circuit is in basic term, which is common for every circuits, one input patient in, one output in.
Thank you.
And a pressure limiting valve to maintain the pressure.
Thank you. Thank you. So usually you're right. So you're doing the bit of oxygenation using the water circuits. You done the checklist, equipments, patient, everyone is ready. And we're going to discuss about the oxylog, the portable ventilator.
Yeah. We do use Oxylog over here in our trust. So Oxylog ventilator, it have a very basic setting that do we need intermittent positive pressure ventilation, either volume control or either pressure control, that option. And we do have SIMV as well, that is synchronized intermittent pressure ventilation. And for oxylate, we can adjust the tidal volume. In oxylate, we can adjust the respiratory rate. We can give some PEEP if patient needed. We can monitor the patient inspiratory and expiratory pressure. So if according to our ventilator setting, we can adjust the BiPAP or CPAP, whatever we want. We do have that option as well. So it's a very tiny machine, about this size, and very lightweight, maybe 2 or 3 kilo. Just the basic thing. And for Oxylog, we do have one again patient input and output side. So there is a special kind of circuit to attach with the Oxylog. One will come from the machine, attached with the humidifier mask patient, and another one will goes to the machine again, so that there is another humidifier, to prevent the expired air to contaminate the theater environment.
Thank you so much. I think it's a very good thing. So I'm just wondering, do we have oxylog in Bangladesh?
I'm not sure.
I'm not sure. Anyone in the audience know about whether we have oxylog in Bangladesh, or is there probably a different oxylog? We're talking about a portable small ventilator that we almost every ED resuscitation bay we use it. or for any transfer, ITU or critical care transfer. I think we may have a different version of portable ventilator, not the one we have in UK. I don't think I've seen it, but anyone in the audience have known any other version of it? Or during our discussion, I'm gonna give opportunity for the audience to speak up or type in. If you have any question, can you just shout out now or type in for Dr. Shamnas to answer? Or if you don't answer anything, if you didn't understand anything, can you just tell us if you have any question?
Well, I have one question. Well, we are commonly intubating. I'm a critical care physician, so I'm intubating in critical care, critically ill patients. So, do we have to adjust the dose of ketamine for intubating critically ill patients or patients who are hemodynamically unstable?
And
Well,
sorry, just before Dr. Menas, where do you work? You said you're in a private corporate hospital. Is it United or where is it?
I was United before, but now I'm working at a new corporate hospital. It's in Green Road, Unico Hospital.
Okay. All right. Sorry. Go for the answer.
yeah. Actually, for critical care ITU setting intubation, we obviously use propofol rather than using ketamine to avoid the adverse effect. In that case, if patient is hemodynamically unstable, we do use inodrop to bring the vitals as normal as we can, and we go for propofol. Ketamine we don't use in UK that much.
Can I add on there slightly? So that's a very good question. If it is unstable, I think it's practiced different in different hospitals. Most of the hospitals still in UK prefer propofol, but in some cases you can still use ketamine. Pre-hospital team, most of the time, I would say 99% or 90%, they use ketamine. Okay, so
I agree.
ketamine is more hemodynamically more stable. But some for in again in Addenbrooke's, why I worked for 6 months in Addenbrooke's. Also in ED, I would say 50-50. So they half of the consultant use ketamine, half of them use propofol. But if someone new to anesthesia or someone in ED register, and if you're not comfortable managing unstable patients, so you are worried about instability, I would rather advise to go for ketamine rather than propofol. However, talking about propofol, I think the side effects of propofol is, if you can you mention some side effects or what are the adverse event you expect using propofol in scenario like this, and how do we prepare or manage these cases?
Uh, Actually, using propofol, what we are worried about that in cardiovascular compromise, that is the patient's blood pressure will drop a lot. The reason behind using ketamine is it will maintain the vital stability, especially the cardiovascular stability. So, and ketamine also influences sympathetic nervous system, which also added on to maintain the vitals in a normal position and prevent the post-induction cardiovascular compromise. For propofol, when we use the propofol, we make sure the patient is well preloaded, that is, had got fluids, had got all the inotropes ready. So if the patient had got any hemodynamically compromise in like blood pressure dropping or bradycardia, we can treat. Rather than treating, we prefer to prevent it with pre-oxygenation and starting inotropes before we go for using propofol.
Okay, so you're considering inotropes before you or IV fluids for if you.
For hemodynamically unstable patient, if it is unstable, so yeah.
And let's say you already used the propofol, you intubate the patient, and then the pressure is gradually dropping. In that scenario, in UK emergency setting, what are the drugs you can use immediately to maintain the blood pressure?
Yeah. So basically, in that case, if patient's heart rate is less than 80, we go for ephedrine. And if it is less than more than 80, then we can use metronidazole for these patients, because metronidazole have some bradycardic effect. Uh, if we are using metronidazole, we do keep atropine or glycopyrrolate in hand, so that patient is getting brady, we can push it straight away. Rather than ephedrine, it will increase the heart rate and blood pressure both in the same time.
Thank you so much. I think in terms of drug preparation, these are the also drugs we considering. I think you did consider to have some metronidazole or ephedrine, atropine ready in case we need post intubation. Okay, so briefly for the audience, you did mention that if it is someone is tachycardic more than 80, you prefer metronidazole. If it is someone is bradycardic, you use ephedrine. Um, can you give us an idea of what sort of dose, like push dose, we use in ED or in resus?
Well, actually, it depends upon how low the blood pressure is. Uh, I usually prefer to check the mean pressure. If it is 65, then well. If it is going down like 30 or 35 kind, then I push ephedrine maybe 6 to 9 milligram straight away. If it is metronidazole, I prefer to give 1.5 to 2 milligram at a single time,
Right.
and we titrate the dose according to the response.
Thank you. So you looking in the mean arterial pressure rather than specific blood pressure. I think that's another thing the audience needs to know, that mean arterial pressure is should be guiding you in terms of using vasopressors. So these are the vasopressors you use in the peripheral IV access. You don't need a central line for that. Um, and let's say you're giving some push dose of metronidazole because of low blood pressure. I'm just discussing for the curiosity part of view. And then you feel like, oh, that patient needs some infusion. Can you start metronidazole infusion in resus?
Yeah, of course. Why not? I have seen in my practical experience, it takes times to transfer the patient from research to ITU or research to other hospital critical care transfer. In that point, we do start to use metronidazole infusion.
Yeah. So I think, how about in Bangladesh? Do you have metronidazole practice of using metronidazole in Bangladesh?
Metronidazole is not available in Bangladesh.
Okay, Dr. Menas, what do you use if someone is crashing in Bangladesh, like blood pressure is dropping? What else option we have
So
in?
we use ephedrine mostly.
Okay, ephedrine. Okay, that's fine. Um, that's a good thing. And in Bangladesh, as I'm because Dr. Menas is there, do you normally go with ketamine rather than propofol? What is the practice now?
We use actually bit of both. Like in my practice, I used propofol as well as ketamine. Like any patients who require bronchodilation, like acute exacerbation of asthma or COPD patients, I'm regularly using ketamine while I'm using propofol for other TBI patients and all that. Actually, I also have experience in working in ED. So in ED patients, I mostly use propofol, but when we take the history and everything, the patient has lung disease and all that, then I use ketamine mostly.
Thank you so much. There's one question from Dr. Ibrahim in the chat box. I'm just gonna go. So he said, if we don't have portable ventilator, what should we do?
Uh, well, that is very important, and that is actually a practical question. Thanks for asking. What I was doing when I was working in Bangladesh, uh, there is a portable cylinder, oxygen cylinder. We use that one as a source of oxygen, and then we manually ventilate the patient.
Manual ventilation
Uh, yeah,
connected with the.
even sometimes we did transfer patient from district to district, like from in tertiary hospital. In ambulance, we also manually ventilate the patient. There might be 2 or 3 person allocated, so that no one is getting tired with ventilation. That's how, for my experience, we did transfer patient. However, I have seen in Dhaka there was some very highly cost ambulances, ICU ambulances. They have a ventilator to transfer patients. I'm not sure which kind of ventilator they are using because I was never been there. but there are some sort of ICU ambulances.
I'm sure. And when you say manual ventilation, what sort of device you use for manual ventilation for transfer in Bangladesh?
Normal water circuit,
Water circuit.
Bain
Oh,
circuit. We use Bain
those
circuit, water circuit, whatever we have, we use.
those circuits. Okay, fine. Thank you. Um, that's a very good question. So let's come back to this scenario. So I think we discussed around preparation, um, drugs, equipments, positioning, everything. Um, so let's say so obviously, can you tell us what happened? So and what happened in this particular case, and when everything is ready, and as you said, the patient was left lateral and then have to put in suit. And so, can you tell us in real life scenario what happened to that case and how did you intubate and what happened, please? Thank you.
Actually, the main part of the intubation wasn't the difficult one, or maximum time. It's not difficult to put the tube down. The main challenge is team preparation, equipment preparation, and made a plan what can happen afterward or what we can do when the patient is crushing. So intubation was quite smooth. Drug was ready, attached with the cannula. There was 3 person who were ready to roll the patient. We needed to maintain the patient safety. One person allocated on my right hand side to put the trachea pressure on. So we did everything synchronically and in my lead, because I that time ED consultant, he left the leadership to me because I was in the head end and my comfortability was the priority at that point only. So on my count, 1, 2, 3, and then we roll the patient, push the medication, patient down, titrate pressure mode, a 30 Newton, and followed by rock uranium pushing. We wait usually for 30 seconds to act the rock uranium. Usually, we don't manually ventilate the patient at that point to prevent stomach inflation. Uh, but I have seen some people, they do very gentle ventilation, especially in the theater setting. I also do gentle manual ventilation when I'm doing for RSI. But for this patient, we didn't do anything. The reason behind that was we had very good pre-oxygenation and patient had lots of vomiters. If we do manual ventilation, that vomiters can goes into the lungs or stomach infection because of the obese patient. So when the patient was down, after 30 seconds, we use deep blade with CMAC, laryngoscope, OG down, tube down, secure the tube, and then monitor the ETC to correct position identified. We attach patient with oxylot, start ventilation, and we start propofol infusion. I mean, everything happened at the same time by different person who was allocated, but it's done about within 1.5 minutes.
Thank you. So I think this is a very organized teamwork that you're describing here. So everybody is allocated and everything happens synchronously. Someone's doing drugs, someone's setting up, positioning the patient, and you took the leadership because you're on the head end. You did mention after rocuronium 30 seconds. Sometimes I think I've seen people waiting for 1 minute. Is there any variation?
Yes. If you ask me what I'm doing in my theater practice, I usually take not less than 1 minute. Sometimes I goes for 1.5 or 2 minutes before I go for laryngoscope. Basically, when a patient is sedated, their airway is already uh, 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 relaxed. We don't wait for the proper relaxation at that point. And another point is we didn't want it. I mean, the name itself is describing rapid sequence. I mean, the sequence have to be rapid. For rapid sequence, 30 seconds is enough to make the patient relax enough to go for intubation. 1 minute, I have seen we do assess the patient. We give some jaw thrush to check how the patient is relaxed. So according to the intubator assessment, if someone is happy enough with the relaxation, for my point, we can go for it. If I was not happy at that point with patient relaxation, I would probably take 30 minutes more for get my appropriate laryngoscopy.
30 seconds more. Yes, thank you. So it depends on how relaxed is the patient, depends as in case can vary. I think in my case, I normally go by 1 minute, make sure everything is relaxed. But thank you. So that patient was, as you described, preparation is the key. Okay. The exact procedure of intubation is not always challenging because you have the CMAC and, putting the tube is not as difficult as having preparation. So if someone is not well prepared, obviously, let's say if it is similar case in Bangladesh setting, how difficult it is. Like for example, how difficult you think it will be depends on what hospital you're working. So can you tell us a brief of idea in practice of Bangladesh and UK, what sort of difficulty or differences you might face of the similar case?
Well,
Sorry, we're going a bit over 11, so I think we just carry on a bit more and finish the case, please. Go for it.
yeah, yeah. For actually, whatever I will say from my past experiences in Bangladesh when I was practicing. If we are going for a rapid intubation for someone, the main challenge is getting team to work uh, synchronistically and tube, getting a tube, airway adjunct, and obviously video laryngoscope. That is one thing we don't use everywhere.
Right. Thank you. Um, so what happened at the end in this case? So you intubated, took it to CT. Can you tell us what happened at the end?
Yeah. Basically, at that point, when we made the decision that patient we are going to do the CT and then plan subsequently according to the CT report. So someone already requested the trauma CT in hospital system, and someone that one was the nurse in charge called the CT room if they are ready or not, because we have to inform them as well. We can't just push the patient over there. And then when that tube was there, tube was secured, then we checked ETCO to correct position, and then we started the propofol infusion with a ramifentanil infusion because the patient had very high blood pressure at that point, and ramifentanil also for anesthesia as well, very low dose. We start 0.2, 0.3 microgram per ml dose, and then we transferred the patient in CT scan, had the CT, found a massive subarachnoid hemorrhage, and then we patient needed neurosurgery referral, and neurosurgeons were happy to accept the patient because patient age, comorbidity, activities, everything. They thought that patient is good candidate to have a surgery. So we needed critical care transfer of this patient in Edinburgh.
Thank you so much. I think that was a really challenging case and scenario. Someone, yeah, with that age range having subarachnoid hemorrhage, traumatic subarachnoid hemorrhage, and transferred to Edinburgh's or major.
Actually, to be honest, for our opinion, that patient had subarachnoid hemorrhage because had headache, and followed by patient had a fall and seizure and vomiting. So
Oh,
the main cause was subarach rather than traumatic brain injury. The trauma happened because of unconsciousness.
so interesting. That is more interesting. So this is also, did the patient has any risk factor for subarachnoid hemorrhage?
Smoking and obesity, nothing else.
Oh, very interesting. Someone having a hemorrhage, fall and head injury. Oh, I'm just thinking, it's how challenging it is. So regardless, I mean, that patient was, I think, well managed from your point of view, and as I understand, in of ED and IT point of view, intubated, went to CT, had diagnosis, and then transferred to Edinburgh's. Um, Thank you, Dr. Shamnas. Again, I think we crossed the time limit already. And if there's any other question from the audience, you can shout out now or you can email me later. In summary, we discussed a challenging case. as someone with 60, around 60 years old, obese person, headaches, subarachnoid hemorrhage, fall, head injury came as a trauma call, vomiting at the same time was predicted as a difficult airway. And we briefly discussed how Dr. Sharma's, how she prepared herself and the whole team, and how she ended up doing intubation and eventual diagnosis and CT. Again, we did discuss a bit more, details on all the steps. If anyone in the audience, if anyone has any other thoughts, please send an email or anything if you think of down the line. And thanks for the questions or some of the comments from some of the audience, Dr. Manas and Dr. Ibrahim. Thank you for coming here. Um, is there anything else you want to add on, Dr. Shamnas, before we close the session? Dr. Shabnas, can you hear me?
Yeah. I was just checking a message. Sorry about that. Uh, actually, for my point of view, what change in my practice, that is in Bangladesh, we don't usually do team working. There is a huge lackings over there. Uh, and we don't allocate a team leader over there very often. That make everything haphazard. Everyone is doing their stuffs by their own. But a team leader can make a difference hugely and close the loop communication. That is one thing. And also, the person who is working in a specific setting, like in ED research, the allocation of the role, like the nurses was there, the ODP was there, the doctor was there, they all knows about their job role. So even if they don't have anything from their part, they just stand beside, they don't involve themselves with any other task. So that is one thing. This case was managed well from my point of view because everyone was working their best in their point of view. The nurses were doing their job, I was doing my job, the medicine doctor was doing by their job, the surgery doctor was doing their job. There was a ED doctor who was requesting everything. Um, the consultant, he knows that when he need to hand over the leadership to me, I had my second intubator beside me to help me and who was experienced enough to help me out. So those everything basically, with those things, we manage the patient very well. However, for me, there is no exact, appropriate protocol that we need to follow 100%. Every case is different. In every case, we have to make decision by our own clinical judgment. For this patient, I don't say we follow RSI completely as a protocol, as a theoretical, but what we had, we did manage the patient based upon the clinical scenario.
Thank you, Dr. Shamas. Thanks for very important point that you mentioned. Let's say you did identify that in Bangladesh we are lacking the teamwork, lacking the team leadership and organization planning part, rather than the actual procedure. I think those are the things, even in ED and IT, we can improve in Bangladesh. Whoever is listening, and we need to focus on more of preparation, leadership, teamwork, than actually the process of intubation, which is not really difficult if you have everything well set and well planned. With that note, again, I'm going to conclude today's session, Dr. Shabnaz. I think I would love to invite you for further sessions and further similar case discussions, because you've been. I think we should use your experience more often on different scenarios, and
Of course.
and the audience will love to hear your experiences. Thank you again, everybody, all the audiences. Thank you for joining today, and we will see you next. Thank you.
Thank you very much for having me.
Thank you, Dr.